So pause while you get yourself ready and just continue and hit play once you're ready with lesson 10 to begin. So here we are in lesson 10, where we discuss MRI of the upper and the lower extremity. We're going to talk a lot about the clinical application of all the physics we've been discussing in prior weeks. And really now it's time to kind of tie it in clinically to patient imaging. And when we talk about patient imaging, we're talking about the fact that each sequence has its own purpose. Obviously, we know from the building blocks of what we've been discussing, T1 is our basic anatomy scan. We always run T2 as our basic pathology scan. And there's a mixture of scan planes that are appropriate based on body part, based on anatomy. And then, of course, even as we discussed last week, or the last week of class before our break, magic angle artifact. The requirement of why we need a combination of both short and long TE sequences in every particular application. Magic angle, of course, being 55 degrees relative to the magnetic field direction, as we showed in the patella tendon. So each sequence has a purpose. In the shoulder, as we start with them, we'll work our way from upper extremity, proximal, or work our way distal, and then we'll do the lower extremity, same thing. We'll start proximal and work our way distal as we get through the entire orthopedic MR lesson. So in the shoulder, common indications or applications are to rule out rotator cuff tear, one of the most common applications of shoulder MR. Labral tear, slap lesion, we'll discuss and define what is a slap lesion, bursitis. When we talk about humerus and even forearm, there's a lot of similarities in all of the long bone extremity work that we talk about, where usually it's to rule out a soft tissue mass. Specific to the humerus, it could be a bicep or triceps muscle tear or bony pathology, and we'll look at a few of those. In the elbow, more athletics or sports-related injuries, we look at tennis elbow, biceps tendon. In MR, a patient that presents with a prescription for biceps tendon dictates an additional set of instructions that we're to follow. So again, there's a lot of critical thinking in the daily applications of MR. Epicondylitis. So all these different indications. Forearm, same as humerus, same as femur, tib fib. Usually it's just for generic pain, bony pathology, or some form of a soft tissue mass. In the wrist, we do get a little more specific, so ganglion cyst, TFCC tear, which we'll define. We'll also establish optimal imaging planes for that, and then pain or fracture, among other things. Often in the hand, pain versus fracture, and then a lot of infectious processes such as osteomyelitis. So moving on with shoulder anatomy, one thing I want to point out with this particular slide, taken from MetaVisuals, when we're examining the shoulder for scapula, keep in mind that our coil selection may be different compared to the routine shoulder joint. A typical shoulder coil really only gives us signal coverage SNR specific to the actual shoulder joint. So be mindful if the prescription or the referrer is looking for examination through and including the entirety of the scapula, that may require a flex coil, a larger coil with additional coverage both in the inferior dimension as well as the medial dimension. And really same applies for a clavicle as well. We'll look at a few examples of that. Again, shoulder anatomy, we're kind of focusing in on the joint proper and the bones and the muscles and the tendons that interact with the shoulder joint. Rotator cuff, we focus on this particular region inside here where the majority of pathology occurs within that particular anatomic region. So we're going to look at some anatomy. We're going to focus on the specifics that are important when establishing or acquiring our images. We're going to kind of have a little bit of a recurring theme in this particular discussion where we talk about angulations and what are the appropriate scan planes that we utilize in MR imaging in almost every single orthopedic application. We want to begin with the axial or the transverse plane because often that's what tells us, the technologist, the appropriate scan plane that's utilized for our coronal or sagittal, very often oblique in nature. So we want to begin the bulk of our orthopedic MR examinations with an axial plane. So here, if you look at the little scan plane, we're a little superior in the shoulder joint, and the first thing we cut through is the supraspinatus tendon, pretty high in our application. This is very important for us to be able to identify, again, all things black in MR, ligaments and tendons fall into that category. So we want to identify the supraspinatus tendon. We're going to use this supraspinatus tendon identification to plan our coronal oblique parallel to the supraspinatus tendon. Our sagittal would then be perpendicular to our coronal oblique angulation. Which gradients are utilized for our coronal oblique planning? That would be a dual combination of our which gradient combination? The YX. Primarily Y because it's a coronal, but it's leaning towards the sagittal plane. So we utilize two simultaneous gradients to perform the function of the slice select process. In this case here, it would be the YX gradient application. So the supraspinatus tendon, the acromion, and we'll move on as we get further down into the shoulder. The coracoid process, deltoid muscle, always laterally located, the infraspinatus tendon, and then the supraspinatus muscle. The infraspinatus tendon kind of housed in the posterior segment of the shoulder, and this is a proton density fat suppressed sequence in the left shoulder. Head of the humerus, the subscapularis muscle. There's a reason why we're identifying these specific muscular anatomies, the glenoid, and then the infraspinatus muscle. As we get further down into a more center cut within the shoulder, and again a transverse cut, we identify the anterior labrum and the posterior labrum, the head of the humerus, and the insertion of the biceps tendon, the long head, the insertion of the biceps tendon. In a coronal oblique view, now we're more posterior, we'll work our way more anterior. We have the teres minor muscle, the infraspinatus muscle, the acromion, the deltoid muscle more laterally located. As we get to a more center cut, the spine of the scapula and the acromion, the infraspinatus tendon, again ligaments and tendons in MR are black, and again the laterally located deltoid muscle. As we get to, as you can see in our scan plane, a more center cut for our coronal oblique acquisition, the spine of the scapula, the glenoid. Here lies our supraspinatus muscle and our supraspinatus tendon coming out. Again, if you see bright, this may or may not be a magic angle artifact. We would use a long TE to confirm whether or not this was indeed pathology. Acromion, greater tuberosity where that biceps tendon inserts. The clavicle, again we're getting more anterior. The clavicle, the AC joint or the acromioclavicular joint, our supraspinatus tendon, the importance of having a really good coronal oblique angulation, and here's our biceps tendon. The proximal insertion of our biceps tendon, we'll see later on in this particular upper extremity section where the distal insertion of the biceps tendon lies. In shoulder, we want to keep the field of view as low as possible. We do want to utilize the smallest coil possible to match that small field of view. You don't want to select a abdominal coil or a torso coil when trying to image a 16 or 14 centimeter field of view. You won't have optimal signal. Instead, a dedicated shoulder coil or a flex coil in that region. Very often we have patients who are too large to fit into the rigid cup of the shoulder coil, and therefore we would switch coils to a flex coil, usually one element posterior underneath the patient, one element exactly matching, orthogonally located in the anterior portion of the shoulder, so you have optimal signal. External rotation and supinate the hand for accurate anatomical position. What do we all know this leads to? Increased pain and decreased patient tolerance. If needs be, you can turn the hand into the shaking hands position. One thing we do not want to do with patient positioning, we do not want to place the hand on the patient's stomach, even though the patient may say that's more comfortable, because you will be prone to increased respiratory motion artifact and have a decreased or degraded image quality. Please watch your prescription ruleouts, different studies, slice plans for scapula versus clavicle versus AC joint. Again, this may or may not require alterations in your coil selection and positioning, as well as your slice coverage or a radiologist protocol. So keep in mind what your ruleouts are in the script before positioning your patient. Medial presaturation slabs used to minimize respiratory motion artifact and vascular pulsation. Drawback to presaturation, again, the more presaturation slabs that are used, the increased TR is required to perform those additional RF functions, but can help to greatly minimize your respiratory motion artifacts. Very important, do not angle your coronal obliques over 45 degrees. If you angle over 45 degrees, most vendors or most systems will give you an indication that now your attempted coronal is now a sagittal, or your scan plane orientation has changed. So be mindful that your images will flip right to left, giving the appearance of the opposite shoulder, or left to right. So keep in mind that you are never to angle over 45 degrees. Often we'll actually go onto the system and we'll implement a 44.5 and then angle down from there, so that it's kind of like a manual entry, if you will, of the appropriate angulation, and then we're sure to not exceed that or over exceed the 45 degrees and have the images flip. One way to compensate for a very steep angulation, patient that's an older lady that's real kyphotic and scrunched over, or man, may have issues with the angle being too steep. So how do we compensate for that? And we want to have the appropriate angulation. You can raise the unaffected shoulder to compensate for the oblique tendon. I will say clinically, this actually does not lead to any increased pain or discomfort in your patient. It actually seems to work very, very well in reducing the unaffected shoulder's angulation of the oblique tendon. Arthrogram shoulders, we'll look at that in a moment, to rule out labral tear, instability, slap lesion, or tear, and that requires an intra-articular injection of contrast material into the joint space for added diagnostic value. This is done under fluoro and obviously under x-ray. 2 mLs gadolinium contrast added to your iodinated contrast saline mixture for accurate fluoro visualization. No need to increase that more. You don't want to intensify your T1 weighted images. Very often the radiologist protocol for an MR arthrogram is to acquire T1 weighted fat suppression in all 3 planes as part of an integrated MR arthrogram protocol. Again, check with your radiologist as far as site-specific protocols that are set up. Intra-articular arthrogram, although it's a little more invasive for the patient, they're useful in the evaluation of rotator cuff tears or slap tears or lesions. Slap tear stands for superior labral tear, anterior to posterior. Occasionally, you'll see a prescription for an IV arthrogram. Can be rarely requested, although you do see it once in a while, and it can be performed utilizing normal dose IV gadolinium followed by 30 minutes of exercise, let's say a shoulder, 30 minutes of exercise in that particular joint, and then we do the MR imaging. Although it can be adequate visualization, it's not nearly the diagnostic value as the full intra-articular injection directly into the joint space. Sample protocol of an MR shoulder. Again, please note that our field of view is pretty small, 16, even 14 centimeters in some sites. Our slice thickness can be anywhere from 3 to 4 millimeters. Again, so that we have adequate spatial resolution and then the number of slices to cover. 2 axials, 2 coronals, 2 sagittals in most places. A gradient echo is a good starting point. PD FATSAT, excellent proton density imaging in all of MSK applications, as you get a really good look at tissue contrast with fat suppression, as well as good ligament and tendon evaluation. So when planning your axial slice group, you kind of go with the angulation of the patient's shoulder. So we kind of go with the AC joint. Through the entirety of the humeral head, please utilize medial pre-saturation slabs or bands for the minimization of respiratory motion artifacts and vascular artifacts as well. You can see that's lying right over the heart for your axial slice plans. Usually 20 to 24 slices in that range is pretty good. So just keep in mind the appropriate slices and coverage that are required. So axial slice groups, coronal angulation will be off of the axial images parallel to the supraspinatus muscle, and the supraspinatus muscle lying right in there. The sagittal approach or application will be perpendicular to your coronal application. T2 FFE, FFE stands for fast field echo. That's a gradient echo axial acquisition. How do we know that this is a T2 star sequence? How do we know this is T2 susceptibility? Because we have a flip angle that's very low in this case here, flip angle of 9, which should give us T2 star contrast, T2 weighting. This 3D application utilizes a 2 millimeter slice thickness, a 15 centimeter field of view, and 40 slices of total coverage in 4 minutes and 40 seconds, which is about average. Again, the supraspinatus tendon is going to be dark, and notice with the T2 gradient echo, the T2 star sequence, it's kind of nice for looking at the overall joint contrast, if you will. Very good for establishing the ligaments and tendons, but you're not going to have tremendous muscular anatomy or anatomic detail. You're not going to see tremendous pathology within the musculature. Bone will always be dark because, again, this fast gradient echo approach, but it does give you a good look at anterior and posterior labrum and a pretty nice sequence for overall overview within the anatomic structures, the evaluation of the labrum, both anterior and posterior. You see a little bony pathology in the scapula as well. So you get a pretty decent look, a decent overview, and gradient echo axial in the shoulder is a standard sequence. Now when you go into proton density FATSAT, please note once you add fat suppression pulses to a proton density, you now increase your tissue contrast. So edema pathology tends to have bright signal. The ligaments and tendons will still be dark, and any pathology in or around them will yield bright or hyper intense signal intensities. So now the most important is our coronal oblique, and angling parallel to the supraspinatus tendon. Please utilize again those medial presaturation slabs, and now you have your coronal oblique where you get a really good look at the tendon coming across, basically indicating that your slice planning was appropriate or adequate. Again, our angulation, we want to ensure that we do not exceed 45 degrees, or again, our images will flip into the opposite direction, and it will mimic or give the look that is the opposite shoulder that was actually acquired. In this T2 coronal as well, Muscle is always dark on T2. Again, that J coupling, please don't look at fat being bright as an indication of, oh, it must be T1. As with fast spinecto or turbo spinecto applications, you can end up with brighter signal from fat than initially intended. This dark bony island here, but again, fluid will always be bright, indicating that this is T2, and muscle tends to have a darker signal intensity, indicating that it's T2 weighted. In T2 fat sat, so again, T2 weighted, how do I know it's T2 weighted? I have a really long TR and a long enough TE. One thing when we add fat suppression to our T2 weighted sequences, the TE does not have to be as long as it would in a routine not fat suppressed T2 to give bright enough signal from fluid. So as you can see, fluid would still be bright in a T2 fat sat SAG, even with a lower TE of around 60 milliseconds. T1, good anatomic SAG, and again that same bony island as being a dark or hypo-intense signal. Even on the scout, you can see that there's pathology, so we always run a scout sequence of about 20 to 30 seconds. That indicates to the technologist we have adequate signal coverage, in addition to identifying, even on the scout sequence, that there is pathology. This patient had a dislocation, fell onto the shoulder. Take a look what normal muscle signal intensity looks like, and when there's damage, that hyper intense signal on proton density with fat suppression, in addition to that bony signal abnormality indicating fracture. Obviously on a T2 fat sac coronal or a stir coronal, we see the same type of pathology. You have fluid within the joint, muscular hyper intense signal intensity indicating damage to that particular tendon or muscle, and then that bright signal within the bone that indicates that there's a fracture or fracture process within that particular humeral head. The again, the coronal oblique in a PD or a T1, that gives you that hypo intense on PD or T1, that hypo or dark signal intensity indicating pathology. Why? We know that the marrow laden or marrow infused bone on PD and T1 gives us that bright signal intensity, and when there's pathology, infection, fracture, tumor, that would give us hypo intense or dark signal intensity. Absolute question we need to know are the four muscles that comprise the rotator cuff. Why we went over them anatomically a few slides prior: the supraspinatus muscle, the infraspinatus muscle, subscapularis, and teres minor. Rotator cuff tears occur when the tendons tear due to injury or wear and tear of the tendons, and the most commonly torn tendon is the supraspinatus tendon in the shoulder. Symptoms of a rotator cuff tear that you want to ask your patients before getting on: limited range of motion, pain, sometimes clicking and cracking inside the shoulder, but almost always there's going to be a limited range of motion. You may have pain right in the front, right in the top of the shoulder joint. Questions that you want to ask the patient for your radiologist to review. Rotator cuff tear, bright signal intensity within a dark tendon structure, and who doesn't like a nice 3D visualized view? In arthrogram, we have an increased signal intensity indicated by the intra-articular injection of contrast, specifically into our joint space, as performed by the radiologist or the resident directly into the joint space, the intra-articular arthrogram injection, increasing our tissue contrast or image contrast for these structures. Often enough in a shoulder arthrogram, there's something called an Aber's view. Aber's stands for abduction external rotation. This would require a different coil setup and position where the arm is above the head, kind of tucked in under the head, so that you can give a different look towards this. you would scan your sequences that would be parallel to the humeral shaft and perpendicular to the glenohumeral articulation. To be honest with you, in our facility, we do a ton of MR orthograms. We actually do not perform this Aber's view, not but once a year, if that, and only on certain indications. So Aber's view with an MR shoulder orthogram, occasionally a physician or radiologist can ask for that additional view. Just keep in mind, you want to plan your slices parallel to the shaft. So what's wrong with this particular planning? Let's look at some QA. Let's look at how we can identify what's wrong with our images. I'll give you a second to look at it. So what do you think, when looking at these images, what do you think is wrong with or could have been done better when planning this shoulder MR? First thing I'm looking at, my field of view is cut off at the tip of the humeral head. So we're actually cutting off the end of the deltoid muscle here. But more importantly, this is a left shoulder. When scanning a left shoulder, if the angulation is too much or too steep and we have exceeded 45 degrees, now the image flips and gives the appearance of what is the right shoulder. So yes, we're scanning the left shoulder. The scout and the planning shows that we're scanning the left shoulder as indicated by the left and the head to left markers. But now notice, you're telling the system that this is a sagittal sequence. How do you know? Now this medial aspect of what should have been the left shoulder is now indicated as the posterior portion. We have tipped the image too far past the 45 degrees that now instead of encoding oblique slices with a YX gradient combination, anytime we exceed the 45 degree cutoff, now it becomes a sequence encoding gradients with a XY gradient combination, X being primary, and the images flip, giving the appearance of the opposite shoulder. Again, we always want to be mindful not to exceed 45 degrees. MRI of the scapula, as we previously discussed, coil placement is vital to success. What do you prefer, flex coils or a body torso coil? We're still aiming for only about a 200 to a 220 millimeter or a 20 to 22 centimeter field of view in scapula. So really the ideal is usually some flex coil combination when trying to image the scapula. Whether or not it's pain versus mass, slice coverage must include laterally through the shoulder, axial to the diaphragm, and coronally posterior through the shoulder joint. Anytime we're looking at mass or pain point and any indication outside of our routine joint, we usually want to put skin markers on the region of interest to identify for the radiologist where the patient complains of pain. So, axial planning, a larger field of view than what you're used to using for a shoulder. Here's your skin marker telling the radiologist where the patient's pain is. Here's a larger skin marker telling the radiologist where the mass or the bump or the lump is. But again, the field of view is a little bit larger than what you typically would use for just the shoulder region. Your coverage is going to go down, again, basically into or through the diaphragm to ensure adequate scapular coverage. Moving on, our coronals are still angled with the scapula, very similar to an actual shoulder. But again, our field of view is larger to cover the entirety of the scapula, and the coverage has to be a little greater as well. I kind of like the slices used here as compared to here, as this seems a little excessive, but we'll leave that one alone at this point. Our sagittals do require additional slices than what we typically would use for a routine shoulder, because we have to cover more anatomic ground, if you will. I've seen a lot of places go from 3 thick on a sagittal to 4s for a scapula, just to not have to run double the number of slices to cover such an increased amount of anatomic coverage. Notice how far medial you go with this, but again, you don't need to go through the entirety of the humeral head, because this study would be just simply for the scapula. So a lot of times we'll see a pathology called a lipoma. Define for me, what is a lipoma? Lipoma is just simply a very benign, so definitely no malignant properties to it. A lipoma is simply a fatty mass or a fatty lump or a fatty growth. So how do we prove throughout all the sequences that we acquire, how do we prove that this is indeed a lipoma? Very simply, we can prove this is a lipoma by looking at fat and assessing whether or not the mass, which is right here, whether or not the mass matches the signal intensity of fat throughout the various applications that we acquire. So on the T1, we know fat is bright, bony signal with marrow is bright, surrounding fat is bright, and so is the area where the lipoma is. Here we can see this lipoma here, this mass finding, and all the rest of the fat is dark as well. Bone is dark, fat is dark, and so is this on a stir. The automatic 180 degree short TI time nulls the signal from all fat on stir, thus proving this is also a fatty substance. We move on to T2 fat sat, where again fat is suppressed, and in the area of the lipoma, so is a signal of suppression as well. On T1 coronal, again, the area of the finding matches the same signal intensity of the rest of fat. Always in a mass protocol, we want to run a T1 fat suppressed axial sequence in almost every single application, especially if we're going to give contrast, because this will further characterize lesion or finding with the administration of gadolinium contrast. I'm not sure if this in particular is a contrast case, but in almost every single mass application, you want to check with the radiologist that the protocol isn't set as to whether or not he or she would like a fat suppressed T1 axial sequence. Now we run contrast, so this is a contrast case, and you see no change in this particular positive finding, this lipoma. So therefore, it has no enhancement of contrast. You see vascularity enhanced, some in the lung with the pulmonary structures as well. But in the area where the lipoma is, there's not an enhancement in that particular area, thus proving this is indeed a lipoma. Different type of pathology in the scapula, you see a dark signal intensity within the bright fat. And as we go through our images, close to where the patient asked us to put the marker on, you see an area of hyperintense signal intensity. This area of hyperintensity shows or proves that this is not a lipoma, that it is a more mass-like finding. And as we go through, we can see that it does not match the signal intensity of fat. So you have a more mass-like finding, possibly a cystic structure, but not a lipoma or not a fatty structure. So again, scapula requires an increased field of view compared to what we normally would run. Coil selection would be vital, and the same applies to clavicle as well. We want to have an increased field of view that we can cover the entirety of the clavicular region. So we have the clavicle here, the SC joint, sternoclavicular joint, the sternal notch, vertebral body sitting here in the thoracic spine, the right lung, the scapula, and the AC joint, acromioclavicular joint. In the coronal plane, a good coronal oblique through the clavicle, the sternum, our SC joint, the clavicle, the acromion here, humeral head, and the coracoid process. So, and in clavicle, same thing, you want to have adequate coverage with your coil that would give you anterior and posterior signals so that you can acquire your images with adequate enough SNR through this particular region. Upper extremity long bone, typically ordered for pain, mass, or tear, both humerus and forearm. From insurance perspective, coverage is mandatory to include joint to joint. Coil position is crucial to diagnostic quality. Very often in a lot of the long bones that we talk about, the axial is going to have a small field of view. The coronal and sagittal will utilize a larger field of view to cover anatomy. Our phase directions in all of our long bone imaging are the number one cause of artifacts for the most part. Anatomically speaking, we do have to supinate the hand for accurate anatomical position, so please be mindful of your patient comfort and speed when going through an exam like this. Again, coverage from joint to joint usually requires either a dual flex coil setup. On a digital system, you can put a flex coil in the posterior table underneath the patient, or you would require a body coil or a torso coil to cover this much ground. But the axials, we always want to ensure that we have a small enough field of view. As we talked about previously when we looked at artifacts, we really want to ensure that we avoid as many artifacts as possible in long bone work where the body is really next to, let's say, a humerus. So we want to implement, if and when possible, AP phase directions. The one thing we do not want to utilize as often as possible is a right to left phase direction, as a right to left phase direction can result in not only wraparound artifacts, but respiratory and artifacts from the body motion. So good small field of view axials with an AP phase direction gives you adequate SNR through this particular region of interest. And a T2 fat set here, again, good adequate SNR. This is even acquired on an open MR using dual flex coils around the patient that we're able to get decent enough images, a whole 40 slice, 2 stacks of 20 approach, so the table moves for each stack of 20, that you get adequate SNR and you don't get drop off at slice 1 versus slice 40. So always try to see if you can move the table per stack of 20 and it'll fuse together into one group for your radiologist. But it definitely gives you adequate signal, and you want to have a small field of view possible on the axials so that you can see pertinent pathology a lot better with adequate spatial resolution. Coronal images, you want to acquire, again, a much larger field of view. Utilize medial pre-saturation slabs or bands whenever possible to, again, minimize any respiratory motion artifact. Utilize a head to foot phase direction for the minimization of artifacts if at all possible. On a sagittal application, you can utilize an AP phase direction and greatly, significantly reduce your scan time through the utilization of a rectangular field of view option. And now this will lessen the phase steps in the anterior to posterior direction, which will save you precious scan time. And again, in our sagittal approach, you can see pertinent pathology as we run through that. So anytime we're looking at a soft tissue mass protocol, the question is always raised, where's the mass located? Which is the best plane to suit what we're going to call our dual cross section? We start with an axial. If we start with an axial, what then would be the best scan plane to be next? If we're looking at it from, let's say I have a mass and the mass is anterior located on the front of the humerus. Once we acquire our axials, if we're looking at, let's say, a biceps mass, following our axials, our sagittal plane would be the best cross-sectional scan plane to visualize something that is anterior. Let's even look at the knee as an example, and we're going to get to that shortly. Anytime we're evaluating the cruciate ligaments, which are housed in the anterior to posterior dimension, our scan plane that's most appropriate is going to be our sagittal plane. However, when we're looking at our collateral ligaments, the MCL, the LCL, one of them is the Tom Brady ligament, right? Anytime we look at the MCL and the LCL, which are housed on both sides of the knee, medial and lateral, always the best scan plane for those will be our coronal scan plane. So again, you want to keep in mind when we're looking to, if we needed to add a sequence, which would be best? It depends on the situation of what we're looking to image. So if something is anteriorly located, following our axials, the sagittal will be the best plane. If something's more laterally located, the coronal would be the best plane for that. Questions for your physician when reading: movable mass versus solid structure, any trauma induced. Use your skin markers. And then with contrast and a soft tissue mass protocol, T1 fat suppression axial pre and post. You want these to match. You don't want your patient to get up in between after you've injected the contrast, and now when you put them back on the table, there's not an exact match of pre to post. We really need apples to apples to ensure whether or not there is or isn't enhancement in the particular area or region. So it is crucial from the optimal image quality perspective to have an exact match of your T1 fat suppression axials pre and post GAD. Always begin the protocol with axials to plot your remainder of obliques dependent upon, again, the location of not only your anatomy but your physiology as well. So here, believe it or not, this was like an 80-year-old guy who was weightlifting and had like that Popeye look to his arm. Felt something pop, felt something abnormal. So it's an axial that we acquire first, but our next best scan plane after these axials are completed is going to be the coronal's nice, but the most optimal is going to be the sagittal because it'll tell the depth of penetration and it'll tell the amount or the extent of this particular pathology. So following on an anterior mass, following the axials as far as order of importance, the sagittal tends to be the most important sequence of acquisition. Lymphoma. Lymphoma, a very invasive, malignant pathology that invades not only muscle, but also invades surrounding soft tissues as well. Not only bone, but surrounding soft tissues like muscularity. So you'll see quite an invasive process of this malignant finding, lymphoma in the humerus. Quite extensive changes in signal intensities that we establish as our abnormals. We know what the norms look like. On a T2 fat sat axial, muscle, bone, and fat are all dark. When there's pathology, you'll have a hyper intense signal intensity in both the muscle and in the bone. Stir sag, same thing. You see the invasive nature from the entirety of the humerus and the muscular involvement as well. Torn triceps muscle in the humerus. So what's wrong with this? As we're evaluating our image quality and how can we make things better, so what's wrong with this? MRI of the humerus, and what's our QA? I'm going to give you a little hint. This does have to do with the coil itself. So what do we have here? A ton of posterior signal and none anterior. As soon as you see this, you should wonder either what's wrong with your coil, is it plugged in, is it on the patient, did the patient take it off? But please don't continue to image. This really is not something that you want to put through to continue to image as far as all this noise and signal and graininess that could have been avoided with better coil position or coil selection. Phase artifact and field of view. We're getting an exact mismatched artifact of ghosting from a fluid-filled breast implant that is getting into the way of some of the humerus anatomy. So again, we're getting some artifact that's getting in the way. Utilization of more appropriate presaturation band and selection of the appropriate phase direction would help in correction of that. In utilizing a right to left phase direction, one of the things that we're concerned about is ghosting. Ghosting from the body and respiratory motion, and the wraparound or the aliasing of the right to left direction. When we switch from, I'm going to go back, a right to left phase direction and all this ghosting, and the only change that's made is we go to a foot to head phase direction. Take a look. We're still using the presaturation slab or band to minimize respiratory motion, but now we've gotten rid of that ghosting in the right to left phase direction. Going from this, which is still passable, it's still diagnostic, to this, tremendous difference and improvement in image quality. It's kind of seemed like I'm a broken record and stressing the point. Humerus, forearm, femur, tib fib, if at all possible, try to avoid the right to left phase directions. So what is wraparound artifact? We talked about it in our last time about artifacts. What is that wraparound artifact? Aliasing or wraparound artifact occurs when anatomic structures exceed or are outside the field of view. Primarily occur in the phase direction, although aliasing can occur in the frequency direction. We know that this doesn't happen due to the Nyquist theorem, in that we're sampling twice per frequency. So basically, in essence, the Nyquist theorem tells us that if you have a 256 matrix, in essence, there are 512 samples acquired. So the use of no phase wrap or fold over suppression can eliminate these artifacts. This is GE terminology, this is Phillips terminology. Can eliminate these artifacts at the cost of half the selected number of averages or excitations, resulting in decreased SNR. Oversampling or phase oversampling are other methods of correcting or anti-aliasing. Again, we've discussed many times already, nothing's for free in MR. On Philips scanners, when we implement fold-over suppression, it's tied into NSA. So if I have an NSA of 4, it takes my field of view and does an entire back folding of it. So in essence, that doubles my acquired sampling or field of view. A fold-over suppression utilizing NSA or NEX of 3 is 75% of my field of view. NSA 2 is 50% of my field of view. So it's tied into NSA. On GE scanners, no phase wrap is just an exact halving of the NEX, and that's what's used to perform the function of the anti-aliasing technique. Increasing field of view is the only method that usually doesn't cost time or major signal loss, but the drawback is, I'll let you fill in the blanks, decreased spatial resolution. So we will lose detail with the increased field of view. Most systems do not allow oversampling in the frequency direction as a selectable parameter because it's inherent. And again, as we discussed, it halves the number of selected excitations. Pre-saturation bands can be utilized outside the field of view of interest to reduce aliasing. So in an 18 centimeter shoulder MR, phase direction right to left, matrix 208, we have 4 necks, and we have a 4-minute scan time. When we enable no phase wrap, our effective field of view is now 360. The matrix sampled is now 416, and there are 2 effective necks with a 4-minute scan time. So we lost a lot of signal, but we corrected the artifact of aliasing, and that's how GE's no phase wrap actually functions. You can visualize it. Again, I like to kind of use a little bit of imagination with this, right? You can visualize it by, here's my small field of view in the shoulder. I really want to maintain that, but in a right to left phase direction, all of this tissue that's outside my anatomy is going to wrap into my region of interest. So I'm going to enable no phase wrap, and it's going to extend my field of view in both directions. Now if I have some tissue here, it's going to start by wrapping around here and working its way in, but it won't make its way into my effective field of view. So a good technique for compensating for aliasing artifacts. So let's move on into the elbow. Routinely ordered for pain or tear. Biceps tendon tear requires an additional axial slices and a larger sagittal field of view to include the radial tuberosity. Skin marker at the region of interest of pain or mass. Please supinate the hand for optimal anatomic position. Speed is essential for patient cooperation, especially in those magnets that don't allow for the patient to be supine with the arm down by the side. Again, from the whole perspective of optimal FATSAT and optimal homogeneity of the system, we want to have the part that we're imaging as close to isocenter as possible, and the elbow is difficult to do that. I see a lot of sites where they'll use a flex coil or a knee coil with the patient in the swimmer's position, arm above the head. The tolerance level, even in somebody young, is literally 10 to 15 minutes tops. So speed is essential for patient cooperation. Put them in the computer, get your protocol set, have everything all set up so when you put them in the magnet and you start your scan, they're on there for as little time as possible, and that will increase their tolerance. Always select the phase directions according to the patient position. If the arm is at the side, keep your phase directions AP and foot to head. Obviously, if the arm is above the head, you don't have to worry about the body wrapping into your tissue. So again, adequate coverage is going to be through the actual elbow itself. However, the bicipital tuberosity is where the distal biceps tendon inserts. So if your rule out or your prescription is to rule out biceps tendon tear, you actually want to cover through the entirety of the radial tuberosity in those patients for biceps tendon. So again, that biceps tendon inserts into the radial tuberosity. When it tears, it kind of rolls up like a cinnamon roll in some patients. But you want to be mindful of the additional required scan planes or coverage. The olecranon, the triceps muscle, very posterior in the elbow. The triceps tendon, ligaments and tendons are always black, fatty tissue. The lateral epicondyle, the humerus, the medial epicondyle, and the ulna. As we get a little more centered in the elbow, the radial head, the radial tuberosity where the biceps tendon would insert, the common flexor tendon. In a sagittal view, and again a sagittal T2, a little bit of fluid in the joint, the brachialis muscle, again muscles always going to be dark on T2, triceps, the olecranon, and the coronoid process, again a sagittal oblique in the elbow. Medial epicondyle, lateral epicondyle, the ulna, and the anconeus muscle. Our scan planes would be exactly, we want to find the epicondyles. We want to use this for positioning for our coronal oblique, and then sagittal to be perpendicular to that. So axials, we're basically just going through the joint, a few slices above and beyond. Again, if it were for biceps tendon, we would go through the entirety of the radial tuberosity. Our coronal, if we planned it well, so parallel obviously to the condyles, we want to have a really good look at the joint space. Very often a physician will look for, same as in the shoulder joint, a T2 star gradient echo, because you get a really good look at the actual cartilage and joint space, as well as evaluating the tendons and somewhat bony anatomy. So again, our slice planning is going to be through the medial and lateral condyles as our positioning, and then sagittal will be opposite to that. So slice plane on our sagittal is going to be perpendicular to the plane of the medial and the lateral condyle. So again, sagittal is going to be perpendicular to the condyles. For biceps tendon, our coverage has to be increased so that we're going through the entirety of the radial tuberosity. So our field of view is increased, our axial slices are increased, possibly even adding additional sagittal sequences to cover the entirety of the radial tuberosity. When the biceps tendon is torn, you have increased signal intensity through where the biceps tendon insertion should have been, and you see a lot of, again, edema and swelling. Occasionally the patient won't even have tremendous pain, they just will have felt a pop, or they will have felt something in their shoulder, sometimes from reaching up and grabbing something, or from exercise type injuries. Radial tuberosity, and that's where the biceps tendon should have been had it been intact. And then again, all of this fluid intensity, hyper intense signal with the tear of the biceps tendon. MRI of the forearm, not a very common application. So forearm is really just, we treat it the same as we would for when we image the humerus, that we have small field of view axials and then large field of view coronal and sagittals. Usually it's for, there's a mass, there's a bony abnormality, but a very rare and uncommon MR acquisition. We spend a lot of time in MR imaging the wrist. Often it's for pain or trauma or a fall or post-op. Common MRI prescriptions are to rule out a TFCC tear or a scaphoid fracture, ganglion cyst even, occult fracture, tenosynovitis, tumor, ligament tear. Very often there's infection, or we're going to identify and define Kienbach's disease. Our field of view in the wrist is 8 to 10 centimeters is optimal. Smaller the field of view, better the spatial resolution, especially if you're in a dedicated wrist coil, because now we have optimal signal to noise, the best spatial resolution we can possibly get. 3 millimeters or less for our slice thickness gives us the best pictures possible. For covering the wrist, we basically want to cover the entirety of the carpal bones into the hand and into the distal forearm, but not tremendously adding anything extra. So capitate, trapezoid, trapezium, hamate, triquetral bone, lunate, scaphoid, bones of the wrist. The hamate bone, the hook of the hamate bone, the capitate, the trapezoid, and the trapezium. So the hook of the trapezium and the hook of the hamate, we're going to need to identify these anatomic landmarks for positioning our coronal oblique. Every single time you run a wrist MR, you start with an axial, find the hook of the hamate, the hook of the trapezium, and that's the angulation you use for your coronal oblique, sagittal perpendicular to it. The flexor tendons, again, being dark, and the median nerve. On the coronal plane, the radius, the scaphoid, the capitate, the trapezoid, the base of the second, because the first would be here with the thumb, base of the fifth, the hamate bone, triquetrum, the lunate bone will identify pathology here, and the ulna. So our slice plan, again, really just axials are going through the entirety of the joint space. Sagittal will be perpendicular, but when we plan our coronal acquisition, it's the hamate and the trapezium. Those are the bony structures that we have to use for every single wrist MR we're going to acquire to give us consistency throughout all imaging. So again, hook to hook in MRI wrist planning. Tenosynovitis, again, what gives us such stellar image quality here is just very simply an 8 centimeter field of view, as you can see here. You have 24 slices at a 2.5 thick, really excellent spatial resolution. You see a lot of fluid in here, a lot of synovitis, so fluid within the joint, but excellent image quality through the use of a dedicated wrist coil, small field of view for optimal spatial resolution, and thin slices for the most detail possible. 3D Watt sequence, so a chest selective fat suppressed sequence, really gives excellent bony pathology information as well as good cartilage detail. So a 3D sequence that uses a chemically selective fat suppression pulse, excellent detail throughout the wrist. Sagittal application as well, good sequence. Again, acquired with the smallest field of view possible so that you get the most detail. Often enough, we can do an arthrogram in the wrist. Again, this would be intra-articular arthrogram. Very often this is post-surgical or to increase the tissue contrast within the wrist joint. T2 gradients are also used in the wrist as well, so that you get pretty good bony anatomy, but that you get good cartilage, TFCC. And then here comes our Kienbock's disease, which you'll need to know. Kienbock's disease, very often seen on MR of the wrist. It's a disorder of the wrist named for Dr. Robert Kienbock, radiologist in Vienna, Austria, who described osteomalacia of the lunate bone in 1910. It's a breakdown of the lunate bone, which is a carpal bone in the wrist that articulates with the radius in the forearm. Kienbock's disease is another name for avascular necrosis. Often we hear of AVN or avascular necrosis in the hip, where it's described as death and fracture of bone tissue due to the interruption of blood supply, and this has fragmentation and collapse of the lunate. So Kienbock's really jumps out at you. So you see this multiple density, multiple signal intensity throughout the lunate bone, as identified by this pathology here, and as identified by the hyperintense signal on FATSAT. Right through the lunate bone, Kienbock's disease. Right through the lunate bone, Kienbock's disease. So it's a pretty obvious pathology, very readily identified, kind of hits that particular bone as an entity. Triangular fibrocartilage complex tear. The optimal plane anytime we're evaluating a triangular fibrocartilage complex is the coronal. So anytime you want to evaluate the triangular fibrocartilage complex tear, we require the coronal plane to evaluate for that. Scapholunate ligament tears, dorsal ganglion. You know, in the old days, how did they used to fix these ganglion cysts? They would actually put the patient's hand down on a nice table, take a big book, a tome, and slam it on top of the back of the wrist, and that was the old school way of fixing dorsal ganglion. I don't think they do that much anymore. Carpal tunnel syndrome. Again, on that median nerve, the signal intensity, the hyper intense signal from excessive hand and wrist and finger use. Vascular necrosis is not only limited to the lunate bone, it can also occur in other carpal bones as well, such as the scaphoid bone. Be careful in smaller body parts of what we call TR burnout. In STIR imaging especially, you can have a bunch of slices that you're adding on from an anatomic standpoint. In this case here, you have 24 slices, let's say. And the TR is 7,200. Sometimes the system will give you a TR of 10,000, right? This TR is so excessive that it leads to a signal loss of stationary tissues, what's called a TR burnout. So be careful of that. Utilizing a shorter TR or multiple packages or concatenations or acquisitions can actually work towards or help towards correcting that entity. MRI of the hand, a little different than the wrist because you need a field of view that's a little bit larger. So be careful with your coil selection. Typical wrist coils only give you coverage 8 to 10 centimeters. But our sagittal and coronals in the hand require a 16 or 18 or even a 20 centimeter to cover a lot more anatomic coverage. So very often we'll use a flex coil, we'll use a knee coil, or something that'll give us greater coverage in the proximal to distal anatomic coverage. Pain, trauma, fall, or mass. The common indications for a hand were a fracture, tumor, ligament tear, or a glomus tumor underneath the nail. Hypothenia or eminence in the palm of the hand. Knee coil or similar size is usually what's used. Very important to flatten the hand when positioning. I love those flat pads that we can get, that we can put. I personally like to, when positioning a patient for a hand MR, I like to put a little bit of padding down. I like to put a flex coil, so I'll use 2 circular 6-inch flex coils that are matching elements, right? I'll put the flex coil down, I'll put a sheet down so the patient's skin is not touching the coil. I'll put the patient's hand down on the sheet, put another sheet on the back of the patient's hand, put the flex coil down, and put a strap across the top of it. Then put a sandbag on both sides. It helps to immobilize the patient's hand and gives me optimal signal. But the most important is that their fingers and hand are in an even plane, so that when I'm obtaining my coronal slices, I have a parallel plane with which to work. So flattening the hand is crucial to really the best signal quality that you can possibly get. Coverage, obviously getting from the metacarpals now and all the way through the distal phalanges. This is really why we want to have as much possible coil coverage to get optimal signal as we can. So the wrist into the hand, we have a particular radiologist that anytime we're imaging the hand, if we catch radius and ulna, our field of view is too big. So be mindful that we can get into the carpal bones, but if we're going all the way into the radius and the ulna and we haven't lowered our field of view, then our spatial resolution could be improved, and he would be wanting us to optimize that as much as possible. So a good coronal of the hand, again, the radius, capitate, base of the second middle phalanx, the head of the second proximal phalanx. Base is always proximal, head is always distal. The IP joint, interphalangeal joint, metacarpal phalangeal joint, or MPJ, the head of the metacarpal, the base of the fifth metacarpal, the triquetrum. So our axials, we tend to have a lot of slices, usually around 4 millimeters thick, around 40 slices is around what we typically use. Field of view as small enough to give us adequate SNR through that region of interest. As you can see, really good spatial resolution. We typically like to run voxel sizes of 0.4 or 0.5. So do the math with a small field of view. Obviously, field of view divided by matrix equals voxel size. You want to have a high enough matrix with that small field of view to give you adequate enough detail in this region of interest. Again, these axials, we ran these at a 14 centimeter field of view with a 169 acquired matrix, recon at a 512. Good coronal application. Again, could have been just a tad bit flatter as well, so we would have had all fingers in one particular scan plane. But again, the planning kind of goes through all four. If it's just for one finger, let's say it's here just for the pointer or just for the middle finger, and where the marker is, you want to focus with the field of view and an angulation that's specific to that particular finger or that particular area of interest. Again, that TR burnout, as I was telling you about before, the TR of 10,000, right? All the slices that we add in a small body part, we simply go from this TR of 10,000 and one package, one acquisition, one concatenation, just to talk about all vendors. We go to possibly 3 of them now. And now with 3 packages, 3 acquisitions, 3 concatenations, I have a smaller field of view and I broke down the slices into groupings so that I have a shorter TR and I didn't have burnout of signal. So keep in mind when stir sequences, you don't want to have a TR that's really too long that you lose all the signal. That's the only thing that's different between these 2 acquisitions. So be very careful with an extensive TR that's too long. So we have opposable thumbs, right? One thing that's a little bit challenging from the MR perspective is when we have to image the thumb in particular. So whereas hand coronals are going this way here with digits 2 through 5, when we want to do a coronal through the thumb, our angulation is going to be completely different. Take a look. Great look at the hand axials, right? But the thumb is turned completely different. So my coronal through the thumb, the system is actually telling me that this is a sagittal. So the system is telling me that I'm acquiring this as a sagittal, even though specifically I'm acquiring a coronal through the thumb. I'm going parallel to the condyle. Then my sagittal will be exactly opposite to it. So here's my axials. My coronal would be here. My sagittal would be this way here as I'm drawing it. So my sagittal goes this way. My coronal goes this way. Now you have a really good sagittal through the thumb. Again, good cross planes because opposable thumbs, they're going to be faced in an opposite direction as compared to the rest of digits 2 through 5. I hope that makes sense. So again, here's your sagittal, opposite to what would be your coronal. Take a nice little break, get yourself a refreshment. You can pause the video for a second, and then we'll come back and we'll discuss lower extremity. Lower extremity, you're going to notice that there's a lot of similarities between what we just discussed in the upper extremity section. We utilize this for detection of, same things, sports-related injuries, trauma, tendon or muscle tears, bony abnormalities, osteomyelitis. Hips, femurs, calves normally require at least one bilateral sequence for comparison. This is the way most radiologists like to require this. Major muscle tears are prime for MR orders because of the superiority in soft tissue visualization and contrast. Often for knee ligaments, one of the most common MRs we do is to evaluate for the knee. And then we're going to talk about in the foot, we're going to segregate hind foot versus midfoot versus forefoot and optimal sequence selection. In the lower extremity anatomy, if we're doing something like the hip, we want to stay in this region here. Hip, actual dedicated hip itself versus femur, where we need long bone coverage, versus tib fib, but the knee we would want a coil specific to that, or the ankle as well. So hip anatomy, femoral head, this is a nice T2 axial. How do we know it's T2? Because we have bright signal throughout the bladder. Superior pubic ramus, you have the labrum, you have the left femoral head, and you have the acetabulum and the ischium as well. A very common anatomic question that could be asked: the iliac crest on the T1, the body of the ilium, femoral head, greater trochanter, the femur, the vastus lateralis muscle, the adductor muscles, the obturator externus muscle, femoral neck, labrum, and acetabulum. Please know this slide from an anatomic standpoint. And it's very important for you clinically. Often we'll see a referring physician that will order an MRI of the hip, but he or she will indicate for evaluation of the adductor muscles, and you want to make sure that your coverage goes inferior enough to cover the entirety of the adductor muscles. So for hips, utilized for labral tear, again, there's that AVN again, right? Avascular necrosis, or bony abnormalities, arthritis, internal derangement, simply defined as damage to internal structures, or DJD, the degenerative joint disease. Option 1 is to use a body or a torso coil for multiple bilateral sequences. Majority is around 34 to 36 centimeter field of view. Option 2 is to use a flex or smaller field of view coil for the unilateral scanning, and you'll use the actual inherent body coil to obtain your bilateral sequences. Abductor and adductor tears, there's a piriformis anatomy or protocol that's also used in a lot of hip MR. Positioning: center 2 inches below the palpable as is anterior superior iliac spine. I'm going to show you a way that you never have to touch a patient ever again. I personally don't like to touch people at all. So you can't miss if you just follow a quick little guideline in hip MR, and every single patient's hip will be positioned to the center of your coil. You'll have perfect signal. We do have to wrap or tape the feet together to achieve correct anatomical hip position. Patients that have tremendous back pain and they come in for hips, put a tiny pillow underneath the knees. It'll just take enough pain off the nerves that they can endure your 25-30 minute hip MRI, which is normally how long they take. Coil elements anterior and posterior for adequate signal. Approximately 1 millimeter voxel size or less for adequate spatial resolution, and we're only using 3 to 4 millimeters. So this is not how you scan a hip with the knees bent, but I just want to show you from a positioning standpoint. I always place the posterior element of, let's say, a body coil or a hip coil. I place the posterior element on the table, and I ask the patient to actually sit on the coil that's laying on the table. I have the patient lay down, and I have the patient bend their knees. At the point where the crease occurs, obviously, is the hip joint. So if they're too far up in the coil, I have them move down. If they're too far down, I have he or she move up. Then I put the anterior coil over the front of that so that your coil elements are matching, and I have them bring their feet down, tape their feet together. Every single time I'm scanning a hip, I'm centered perfectly to the coil, and guess what? I don't have to touch them. So again, this is not how you position them for a hip MR. This is just simply how do you center them appropriately to the coil so that you get the exact best signal possible. Bilateral hip coil versus just a flex coil anterior to posterior. You have to make sure that your inherent body coil can scan the bilateral for when you do your bilateral sequences. Bilaterals are 36, 38 centimeters compared to your unilaterals, which are 20, 23, 24 centimeters. Big difference between the two. So again, our coverage basically wants to be basically below the as is, down through the entirety of the lesser trochanter for coverage in a hip MR. Almost every single place I've ever worked at in 20 years of doing MR covers bilaterals so that you can get adequate coverage, and then unilaterals on the one side as well. When you're planning a unilateral coronal, utilizing opposite medial pre-saturation slabs to avoid aliasing artifacts, and going parallel to the femoral neck. Sagittal, opposite to that, so just straight sagittals. Almost every single place that I've seen lately is running the oblique sequences that are useful in the diagnosis of femoral acetabular impingement, or FAI. And this oblique sequence is off of your coronal sequence, parallel to the femoral neck. It usually comes out like a sagittal, but can also be an axial if their hips go out wide. So this oblique sequence, common to almost every single site that I've seen lately. If it's unilateral coil positioning, you're just using flex coils, totally fine. Use the body coil to then acquire your full bilateral comparison sequences of both sides. Usually a T1 and a T2 fat set or a stir to compare both sides, and then the unilateral imaging where you're doing one side and you're acquiring them. Very often you're going to see T2 star gradient echo sequence going through the hip joint. How do I know this is T2? Based on a shorter flip angle of 35, 3 thickness, and a small field of view with a 372 matrix. So you get a really good small voxel size. Greater trochanter fracture. So this fracture that we see is evidenced by hyper-intense signal intensity. This hyper-intense signal intensity is obvious because you have on fat suppressed or stir sequences, you have the marrow suppressed, and where there's pathology, you have hyper-intensity to that pathology. On T1, that fracture is dark in signal intensity, or hypo-intense. On the unilateral, not only is the greater trochanter evidencing hyper-intense signal, but also the surrounding soft tissues or muscularity, as you have an increased extent of the pathology to that region of interest. Again, on T1, you're going to have dark signal to that greater trochanter fracture. AVN, that loss of blood supply and interruption of blood supply. Avascular necrosis, most commonly found in the hip joint. Again, we did see it in the wrist as well with the Kindbox. Labral tear. So the labral tear, basically the common injury in athletes. Often we're going to use intra-articular arthrogram to evaluate for labral tear. Often your scripts can say MRI of the hip to rule out piriformis. And when you have piriformis muscle tear and you want to evaluate for the piriformis, you want to have slices that will cover more medial as well, so keep that in mind. Moving on into the femur, again, you want to have smaller field of view axial and longer field of view coronal and sagittal, same as the other long bones we've been discussing. Here you do want to wrap or tape the feet together to achieve correct anatomical position. Fat suppression is always going to be critical in extremity imaging. And 2 stack axials, so you can move the table per stack. It's really the optimal method of getting the best image quality in those acquisitions. Anytime we're doing long bone imaging and we're imaging pediatrics, we want to utilize in and out of phase T1 weighting for pediatric MSK imaging. This is going to help to differentiate bone marrow invasion from other processes. So you want to impress your radiologist, pediatric imaging long bone, add the in and out of phase, usually a coronal, so that they can compare both sides and they can evaluate any bone marrow invasion from other processes. Here are your TE values of what is in phase versus out of phase. So if you're imaging at a 1.5 Tesla magnet, 2.3, 6.9, 11.5, 16.1 are those values that would be out of phase at 1.5 Tesla. Coil position, we do want to be adequate to get from joint to joint. Again, usually an abdominal or torso coil or anterior coil with posterior elements is adequate. So that again, you're going to keep those axial slices with a field of view that's low, and then the coronal and sagittal with a larger field of view to cover the area of interest. Very similar to the lymphoma case that we looked at in the humerus, liposarcoma, where you have invasion with this malignant pathology in both the bony abnormality as well as in the surrounding soft tissues. So liposarcoma is a condition that affects both bone and soft tissues. It will be T2 bright and T1 dark, and typically has a pretty significant enhancement if contrast is administered. And this looks like this would be the post-contrast imaging, where you see the enhancement within the specific area of malignancy. This thigh mass, we talked about this earlier. What might this pathology be? So we look at the extent of what looks abnormal, looking at the medial right thigh compared to the patient's left, and you see something that looks pretty extensive. But as you go through the entirety of your images, what is it that you notice? You notice that on all images, on all acquisitions, it matches the signal intensity of fat. So therefore, this must be a lipoma. It doesn't enhance with contrast, and throughout all of the sequence acquisitions, it matches the same signal intensity of fat. Therefore, it must be a lipoma. So we talk a lot about the importance of resolution and how it affects. You have a case here in the distal femur where you have pretty extensive pathology, and this extensive pathology that you're looking at is only evaluated or only visualized through appropriate image quality, resolution, and detail. I've been talking about it for how long and the importance of it, and we keep stressing it. Let's look at what happens when that gets degraded. Look at this next image. This is a world of difference in clarity when you look at this image here. I'm going to go back one to the first image we looked at. Same patient. Here's your T1 and here's your T2. So what happened? What happened that these images are so significantly degraded? Let's take a look at the parameters behind it. So let's establish our voxel size. The formula for voxel size in MR is field of view divided by phase matrix, or divided by your matrix equals your voxel size. So in the first image we looked at that gave us adequate spatial resolution or adequate detail, we employed a 200 millimeter or 20 centimeter field of view, and we utilized 336 for our acquired resolution or matrix. So 200 divided by 336, our voxel size is 0.59, and let's just say 0.6. 0.6 millimeters means you have the ability to distinguish between adjacent structures. Now, this scan took 4 minutes and 45 seconds, so it's a long enough scan time, but let's take a look and see what happens when the tech came in and said, you know what, that 4 minutes and 45 seconds is too long and I want to get out of here today. What did the tech go in and do? Now, the 20 centimeter field of view, they went in and instead of acquiring, I'm going to go back one, instead of acquiring a 336 matrix, they went in and they cut that in half to a 128. Now, this results in a 1.56 millimeter voxel size. What does the image show? Way less detail, a lot of blurring, a lot of blurriness, and really what you can define as subpar image quality. Yes, the sequence scan time was only 2 minutes and 17 seconds, but at what cost? The cost was adequate detail, potentially missing minute pathology, and not being able to see as clearly as we should have been. It wasn't for matter of signal, it wasn't for matter of coverage or coil coverage, simply it was that the matrix didn't match and the voxel size wasn't appropriate to what we were imaging. Same thing, a sagittal, tech goes to a 400 field of view, a 400 millimeter or 40 centimeter field of view, and a 256 matrix, 1.56 millimeter voxel size, very subpar as far as the adequate resolution, or really what it should have been. So going on to the knee, and I hope that makes sense to you. Going on into the knee, one of the most common MRs that we're going to do, utilized in the evaluation of trauma or injury, the severity of ligament or meniscus tears, angulation of the obliques, critical to diagnosis of pathology and the grade of tear, our high-resolution scan plane, 3D scan planes for knee replacement protocols, small field of view, 3 thick, gives us good spatial resolution and image quality. I will say one thing, especially when there's larger knees, be very careful when closing the top of the knee coil on the patient that you don't pinch the skin. So be very careful when closing that knee coil. Center 2 centimeters above the apex of the patella. So I just put that little marker right here so that your appropriate centering point, if you want to get right to the middle of the joint space, we're going to center 2 centimeters above. Here's the apex of the patella. 2 centimeters above is appropriate for MRI of the knee positioning. What are you going to ask your patient for your radiologist information and that they can make the most accurate read possible? Was there trauma or injury? Blunt trauma to the knee? Which side? Is there pain medial or lateral? Is there clicking or cracking? You want to know if there's any swelling, and was any fluid drained by the doctor? Was it fluid? Was it blood? Is there posterior tightness? If they say there's a pulling in the back of the knee, often that indicates ACL damage. Do they have ability or inability to weight bear? History of any dislocations, because that can also lead to recurrent damage. Do they have a history of OCD? This is not obsessive compulsive disorder, but osteochondroma. That can create additional pictures that are required of us. And then, of course, is there any prior surgery? We've talked about metal artifact reduction techniques. Very often in ACL surgery, they use metal to anchor their ACL to the bone, and that may require our corrective techniques like a wide bandwidth, no fats at, use stirs, and a very small slice thickness high matrix to compensate for metal. So again, the cruciate ligaments, best seen on the sagittal plane, but the LCL and the MCL, the collateral ligaments, are always best seen on the coronal plane based on their positioning and how they articulate. We always want to look at the menisci, both medial and lateral meniscus, in every knee MR we're going to do. The anterior cruciate, one of the most torn athletics or sports-related injuries versus the posterior cruciate ligament. The lateral and medial collateral ligament, also known as the fibular collateral ligament, and the tibial collateral ligament. The tibial plateau, the fibula is always going to be on the lateral side of the knee. So we have to always keep that in mind when looking what side of the knee we're on. The fibula is always identified as the lateral side. So when we're looking at a PD sag of the knee here, we're identifying pertinent anatomy. Here's your patella. Here's the femur. How do I know which meniscus? So you want to see a black triangle as your identification of the meniscus. How do I know which meniscus I'm on? Okay, this is the anterior, this is the posterior. I can establish that by the position of the patella. But how do I know if I'm medial or lateral? Based on here's the location of the head of the fibula. So I know that this here indeed is the posterior horn of the lateral meniscus. And then this is the anterior horn of the lateral meniscus because I can evaluate or see the head of the fibula. Going to a more center cut, your quadriceps tendon, the patella tendon. Last week we looked at the patella tendon when we saw the magic angle artifact. Here's the patella itself, distal femur. Posterior cruciate ligament, always the larger of the two. And here's the anterior cruciate ligament. Obviously, this is more anterior than the posterior cruciate ligament and the tibia. Very often you're going to see anatomic slides based on T1 or proton density. How do I know which is which? Take a look at the TR and TE. I'll give you a second to determine if this is T1 or proton density. So the TR is long, 2000, the TE is 22. So this TR is long enough to minimize any T1 information. This is proton density of the knee. anterior horn of the lateral meniscus, because there's the fibula and there's the posterior. Our quadriceps tendon. Here's our anterior cruciate ligament, the ACL. Here's the patella tendon, and our posterior cruciate ligament. Again, an excellent anatomic overview of the knee. Very common axial slices through the knee with a lot of appropriate pertinent pathology, anatomy for you. So here's the right femur. Here's the patella, the vastus medialis muscle, the sartorius muscle. On PD fat set, the muscle's going to be gray. On T2 fat set, the muscle will be dark. The medial condyle versus the lateral condyle. The lateral head of the gastrocnemius, the medial head of the gastrocnemius, the lateral epicondyle in the corner, articular cartilage, basically the femur to the patella, the intercondylar fossa. By the way, one thing to notice, the lateral and medial head of the gastrocnemius muscle. The gastrocnemius muscle is basically the proximal posterior calf muscle. A lot of runners will tear this, but notice how high the muscle goes up. So anytime when imaging the calf for gastrocnemius muscle, you have to scan up to and including the entirety of the patella, so you get the entirety of the medial and lateral head of the gastrocnemius muscle. Then you have the lateral patellar retinaculum and the medial patellar retinaculum. Often these can be torn when there's a dislocated patella, and that's why we asked the question. Also, you want to be able to evaluate the anterior cruciate ligament. Every axial that you run, when you run that first, you're going to use that to identify the location of the ACL for when you plan your ACL thin slice sagittal. Usually it's going to be parallel to the lateral condyle, and it's going to be in the lateral side of the intercondylar fossa and then the posterior cruciate ligament. The coronal PD fat sac coronal, the lateral collateral ligament is housed in here. The medial collateral ligament is in here. Medial femoral condyle, tibial plateau, medial meniscus, black triangle, lateral meniscus, black triangle. Sample protocol, T2 fat sat axial or PD fat sat axial. Then you'll have a PD fat sat sag and a T2 sag. Again, your site could be different. 16 centimeter, 3 or 4 millimeters thick, a number of slices to get through, and then often most sites will ask for a T2 sag of the ACL. Small field of view, really thin slices just through the ACL itself. Baker's cyst, posterior located. How do we know it's a cyst? Because on T2 or T2 fat sat, we get a lot of hyper intense or bright signal intensity. Again, Baker's cyst, when you run your coronals, you want to make sure that you're back enough and through it in its entirety. So again, a good pathology that you see, patient will complain of a lot of posterior swelling. When planning for the ACL, you want to basically be parallel to the lateral condyle and in the lateral section or side of the intercondylar fossa, and also off the coronal image. It's almost like hands in the pockets, right? If this is a right knee, you want to be almost angled with a 15-degree internal rotation, like hands in the pockets, if you can picture it that way, to get a really good look at the ACL in plane or in profile. So this meniscus tear, as evidenced by, you know that normal meniscus is a black triangle, and then when you see hyper intense or varying signal intensities, that's identifying the meniscus tear. Again, same thing, bright signal intensities within what normally is a dark or blackened triangular structure indicates meniscus tear. And then same here. You're looking at the abnormal signal intensities as meniscus tear. Before the window leveling on PACS and we had to print everything, and I'm kind of dating myself by showing this, but I have to show you anyway. The meniscal windows used to be the way we'd have to print our T1 coronals with a zoomed up image and a salt and pepper, really bright looking bony interface so that you can see the meniscus a lot better. This meniscal windows, again, now normally a doctor will do that on PACS as they're going through making their readings and their adjustments from there. the old school way of doing it. You really want to impress your radiologist? Identify for them this meniscal flounce. Meniscal flounce almost looks like a staircase throughout the meniscus. Kind of has that jagged look to it, where it's cystic but yet not. And that meniscal flounce, that jagged structure, is kind of a rare finding. Very often it does not have to be trauma induced, but the patient can have recurrent pain and symptoms from it. So the meniscal flounce, a really neat finding that we really only see once or twice a year with all the MRIs that we do in our place, but definitely something you want to impress your radiologist with when you see it. So this is the tear of what? We'll say meniscus. Is it medial or lateral? We're going to say it's the medial meniscus. Is it the anterior or posterior? We know that it's the posterior location. Popliteal cyst, the only difference between popliteal and Baker's is that it's on the popliteal artery. So it has a little bit of a different effect and can have an impact on the overall blood flow. PCL, posterior cruciate ligament, versus ACL, the anterior cruciate ligament. ACL and MCL tears, you can't see any of the integrity of the ACL, and obviously it's torn. A really good descriptive of what an ACL could look like and the disparity of what should be that ligament in its entirety that's no longer. Patellar dislocation, we know by overall anatomy and just basic x-ray anatomy, the patella should be anterior, except when it keeps dislocating. So you can have a tear of the retinaculum, obviously a bundling of the retinaculum, and the patella is all the way off to the side. When you do a coronal image and the patella looks like a sagittal, you know that you have some significant dislocation going on. All the way off to the side and you're at the fibular head, and there goes the patella, significant patellar dislocation. So again, thin slice ACL, you want to see integrity from top to bottom as indicating the appropriateness of your angulation. 15 degree is often what indicates the ACL angulation. One last pathology I think is Osgood-Schlatter disease. Here you see some pretty significant pathology in the distal insertion of the patella tendon. So this pathology in the patella tendon that's inserting into the tibia or the tibial plateau, the tibial tuberosity, is Osgood-Schlatter disease. Typically what we see in Osgood-Schlatter disease is we define it as inflammation of the tibial tuberosity and patella tendon, and often we see it in preteens, and it ends up subsiding throughout the teenage years, but often we'll have a knee MR ordered, and the preteen will have anterior proximal tibia pain. We'll want to look for Osgood-Schlatter disease as the indication. Bone bruise, hyper intense signal intensity, pretty obvious and usually traumatic. And pediatric adjustments, thin slices as possible, a small field of view as possible, so that we can get the most optimal spatial resolution that we can. Almost finished with our orthopedic MR lecture today, and we're looking at the tibia and the fibula. And again, with long bones, Gaucher disease kind of gives us the almost bell shape, if you will, or hourglass shape to the bony structure. What we do want to do in Gaucher is running in and out of phase to evaluate the fatty lipid buildup in organs and bone marrow. So Gaucher is one of those. That gastrocnemius muscle that we were talking about earlier, how high the head of the medial and lateral goes. So you want to make sure that you're above the patella when examining that. Take a look, the Achilles tendon, the thickest tendon in the body, going up into the soleus muscle, and then further up, more superior into the gastrocnemius. When the gastroc and the soleus muscles are torn, you see a hyper intense signal intensity in the muscle, whereas normally on T2 fat cell or stir it's dark. So that hyper intense signal intensity indicates pathology. Axial stir, normally muscles really dark with fat, and you have that hyper intense signal intensity and the edema within that region, indicating that there's a tear, indicating that there's pathology within these structures. MRI the ankle, dedicated foot ankle coils preferred to provide improved SNR or overall image quality. You do want to keep the foot in flexion if the patient can tolerate. You want to have that good 90 degree. Ankle versus foot, what's the script say, what's the rule out? Low field of view except for Achilles tendon where you have to go up to the mid-calf. Talus oblique axials, we'll show you that. And usually it's 3 to 4 millimeter slice thickness for improved detail. Again, we look at a lot of the ligaments and tendons that can be torn in ankle imaging especially. So when looking at anatomy and basic anatomy, T1 weighted, short TR and short TE, sagittal of the ankle. Here's the Achilles tendon, again, ligaments and tendons, always black and dark in MR. Our calcaneus bony structure with pathology, our talus, and our tibia there. In a PD, fat side of the axial, Achilles tendon, calcaneus, the peroneus longus tendon, cuboid, lateral cuneiform, intermediate cuneiform, and medial cuneiform. Very important slide anatomically. In a few minutes when we look at the angulations for the coronal oblique and the angle, it's most important that you're able to present to the radiologist an image or two that gives all of the joints within 1 to 2 slices so that they can assess as to whether or not there's any pathology. So here's your fibula, the calcaneus, the lateral malleolus. Here's our mortise joint, also known as the tibio-talar joint, the talus itself, the talofibular joint, obviously the articulation between the talus and the fibula, the medial malleolus, the tibia, and then what's below the talus is our subtalar joint. We need to be able to readily identify these joints within looking at a coronal oblique of the ankle. And again, looking at the talus and the various anatomy. Typical protocol, 3 to no more than 4 millimeter slice thickness. The talus oblique at 2.5 with as small a field of view as possible to give you the best detail. You want to have good flexion position of the ankle and good signal. We want to position our sagittals parallel with the calcaneus or perpendicular to the joint space. We want to position our axials through the actual joint space. And then our coronals are going to be through the medial and lateral malleolus so that we get in one plane the medial and lateral malleolus that's going to be perpendicular with the joint space. Our talus oblique is going to be tilted forward where our normal axials are through the joint space here. The talus oblique goes parallel to the talus itself, ending in an elongated view. Calcaneus fracture. On T1 you see that hypointense signal. On T2 or stir you obviously see that hyperintensity indicating the fracture or the process. Calcaneus fracture in the axial view as well. And then the coronal plane, pretty obvious entity of pathology. Very often we're going to do an MRI of the ankle for Achilles tendon tear. Again, inside a tendon, ligament or structure that's dark, when there's pathology, we have hyper intense signal intensity. So on T1, you have this bright signal, most appreciated on the stir or the T2 fat side. It's going to be the bright signal and the swelling inside the Achilles tendon. In the axial plane, dark tendon is normal. Now you're seeing this bright signal intensity within the tendon, right where the tech positioned the marker, and you can see clear as day the tear of the Achilles tendon, always appreciated by the disparity or the abnormality in the signal intensities that defines MRI's strength in soft tissue visualization. Getting into the MRI of the foot, distal phalanx, middle phalanx, proximal phalanx, and the distal and proximal interphalangeal joints. The head of the metatarsal versus the base. Again, base is always proximal, head is always distal, the navicular and the cuneiform. In the axial view, which looks like a coronal to the foot, but it's an axial to the magnum, we'll talk about that in a second. the MPJ, the head of the first, the head of the third, proximal phalanx, the head of the fifth versus the base of the fifth. Here's the shaft of the metatarsal and the cuboid bone. So what defines what we're scanning? Is it midfoot versus hindfoot? Here we're looking at hindfoot could be anything in the ankle. Midfoot is basically you're just looking at that midfoot region, and forefoot is anything that is metatarsals forward, metatarsals to the toes. If you have a script that says MRI of the foot, rule out posterior tibial tendon tear, you're going to scan it like an ankle because that's looking for the tibial tendon tear in the ankle. But if it's rule out Morton's neuroma, that's always going to be in the toes or in the ball of the foot. So it's really you're looking at, well, I have a foot authorization. It could be an ankle, midfoot, or forefoot. And it's up to you, the technologist or the radiologist, to determine appropriateness based on the rule out, based on the indication where the patient puts the marker. So now we come to the fun of foot positioning. We always start with, off the sagittal scalp, we start with what we call our coronal positioning. Now this coronal positioning, the image comes out like this, looking like a short axis axial. So this is a coronal to the magnet. Picture a patient's laying supine on the magnet. This is coronal to the magnet, but the image comes out looking like an axial. Off of this image, what we have to do is called the double oblique to get the long axis or the axial. We have to angle with the metatarsals here and with the metatarsals here, both angulations, to give this axial. The sagittal will be perpendicular to that. So the sagittal will just be perpendicular to the angle that we used for our long axis. And let's take a look at those images. Here is just our coronal, which comes out like this, our short axis. We use this to plan our full axial view, which comes out looking like a coronal. Sagittal is opposite to it. When it's plantar fascia, we have to get insertion in the calcaneus to insertion in the ball of the foot. So plantar fascia, we have to cover. This is the plantar right here, the black line. So when we're covering plantar fasciitis in any foot MR, a lot more slices are required, usually 40 to 44 to 48, to cover from the insertion in the calcaneus down into the ball of the foot. So we have to cover that much coverage anytime it's plantar fasciitis. Here we have a couple of different pathologies. We have a stress fracture and we have a ganglion cyst. So stress fracture here, ganglion cyst here, and we'll scroll through it and look at it. Stress fracture, obvious increased signal intensity in this region here versus the ganglion that you see here. Ganglion cyst versus the stress fracture. Osteomyelitis. What defines osteomyelitis? Infection. A lot of times they're diabetic. And what is the importance? Whether or not the osteomyelitis has invaded or gotten to the point of getting into the bone. And this would dictate or require amputation. So it's important for us to image these patients as quickly as possible, but please keep in mind as safely as possible. When imaging for osteomyelitis, often the patient has a cream on, they're painful to the touch, it's very uncomfortable for them. So please keep in mind that when imaging for osteomyelitis, they can be very uncomfortable when positioning them. Try to scan as fast as possible with as low of a SAR setting as possible so they don't heat or burn. You can see the invasion into the toe there as well, and that's a patient with osteomyelitis. All this invasion in the toe there, this may already have been an amputation. So foot to rule out osteomyelitis can be very challenging from our perspective and ensuring patient compliance and patient comfort. Again, already post-amputation, is there any spread to the rest? Localized with skin marker, watch for skin creams, as sometimes they can be used with like a zinc or some kind of a metallic cream to them, so be careful. And fat suppression is critical for contrast foot exams. Volume shim should include as little air as possible. One last imaging option is clear. What is clear? It's constant level artifact reduction. I think other vendors call it pure or bright balance. Clear uses a reference scan to perform this tissue calibration scan. So we don't use clear with metal artifact reduction sequences or things like that. Also not to be used with pre-saturation slabs or spine coil sagittals because there's too much snow or signal loss in those other regions. Clear is going to be an image uniformity option that's going to balance out your signal intensity throughout your image. Let's take a look at clinically what it looks like. If we don't have clear on, especially in a foot, right? You have really bright signal in the toes, kind of darker back at the metatarsals, and then you have all this noise and snow in the background. You turn clear on, the background is dark, nice and dark, and you have an image uniformity throughout your image. And that's all it is. Go to the next image. Same thing. You really can't see pathology in the toes, but you could maybe in the tarsals and the metatarsals. But notice the background's real snowy. You turn clear on, and now that background graininess is removed. You have a uniform image intensity throughout your image. Use these options to your advantage. All it costs you is a 30-second coil reference scan. Well worth the improved image quality that you see here. Even in T2 FATSAT. All this background snow and noise compared to a cleaned up, more uniform image, definitely improvement in image quality. If there's any questions, feel free to write, send me an email. Glad to have you on board, and thanks so much for watching. This is Chris Giordano, and I'm signing off.